All right. So let everyone get settled. Today we'll talk about COVID-19 and vaccines is really the main focus. Next week, I'll be speaking to specifically what's going on in the Bluewave medicine medical practice. Today, we're going to talk about sort of the different vaccines and what to think about with respect to those vaccines, how good they are, what their side effects are. Mostly the Pfizer, really going to speak to around the Pfizer one, the Moderna one, the Johnson & Johnson. And then also a bit about the variants that are out there of the different viruses and how effective these vaccines might be against those variants. I also want to talk about, like, if once you get vaccinated or if you're hanging out with someone that is vaccinated, what's the chances of you getting sick? What's the chances of someone that's vaccinated basically transmitting it to you? So that's sort of the coverage that we hope to walk through here today. So as I'm talking, as we normally do, if you have thoughts, questions, please throw them in the Q&A, and then we can sort of make our way through those and address them either in real time or sort of, as I'm talking. So let me go ahead and share my slide. So give me a sec here while I'll start to do that. Great. Okay. Hopefully you see the full display there, not the presentation side of it. So to organize myself a little bit. So, all right. So if we're thinking about vaccines, let me just start with, how do they work? What are the findings that we know? Do they reduce transmission to other folks and once you're vaccinated? And what should we think about these variants? And should we be double masking? And how should we think about sort of living in the space even once we're vaccinated, before we're vaccinated? How to think through some of the thinking around how do you interact with other people to reduce transmission? What are some of the variables to put in place? Meaning physical distancing, masking, ventilation, those three things, and how they can come together, and how can use each part in various gradations depending on if you're in an indoor environment, exterior environment, and things like that. So thinking about the vaccines in general, and I want to thank Monica Gandhi at UCSF, who really I was able to get a lot of these slides from, and a lot of the thinking about this from. So this is a slide that really talks about there's 6 main vaccines out there that we're speaking to. Not all of them have published trials, published reports on them. Some are press releases like the Johnson & Johnson. But this is where we're at. In the United States, the top 3 are the ones that are going to now be available to us. And so that's the ones we're really going to focus on here today. And if you're thinking about it as a complicated slide, but really what this is a nice summary slide that really looks at all the vaccines, which ones are mRNA. Obviously, the first top 2 are, not obviously, but the top 2 are mRNA virus types of vaccines. The Johnson & Johnson one is not. It's the more traditional one that uses an adenovirus, and DNA, so therefore it's different. That one only requires 1 dose. The other one 2 require 2 doses, and the Johnson & Johnson one just needs to be refrigerated, whereas the other ones need to be in freezers, and particularly the Pfizer one needs to be in what's typically a research-only type of freezer, super cold freezing. and how effective they are. And you can see here in this summary slide that they're amazingly effective. I mean, this is like, who would have thought? I mean, you compare this to, for example, the influenza vaccine, which is anywhere between 20% to 60% effective, depending on the year. And look at these numbers here. So what we see here for hospitalization, severe disease, and even milder disease is really strong effects, which is great to see. And we'll talk a little bit more about that. The other thing that is important in this slide is what we look at for the non-clinical results is we talk a lot about the different types of military, if you will, in our immune system. So we have antibodies that come from B cells that create antibodies, and they also create memory cells, and you have T cells as well. And those T cells are a robust part of this immune response as well as neutralizing antibodies. And here's a nice sort of slide to speak to that, where you've got the T cells and B cells. Within the B cells, you have these plasma cells that make antibodies, and you have these memory B cells that stay around for quite some time. And then you have your T cells as well, and different types of T cells. So the reason this is important is some people, for example, that are on certain medications for autoimmune conditions are having, for example, their B cells, circulating B cells affected. And therefore, they may not have as robust as an immune response. And there's concern about that, how protected they'll be once even they're vaccinated. But the good news is there's many other parts of our immune military, if you will. You know, there's a Navy, you got the Air Force, Navy, et cetera, Army. And so there's a range here, even if one part's taken out. And T cells are really important because they will help modulate the severity of the illness. And we know that a strong T cell response has been shown to prevent severe disease. We also know that there's cross T cell immunity. So if you lived in parts of Asia or other parts of the world where there's certain coronaviruses around, or even those of the common cold, those people that have certain cross T cell immunity will have milder disease from COVID. And we see it again if you get infected after you've been infected once before naturally or after vaccine, it's always a much milder disease. And there's a couple case reports of now these folks that have survived, and when they were young in 1918, they were 3 years old, and they were around for the 1918 influenza epidemic or pandemic, and here they are now still with neutralizing antibodies to that influenza. So pretty amazing, the memory of our immune system. So just sort of walking through some of the different vaccines. The Pfizer one, is a big study, 43,000 people, nice and varied, about half women. It was mostly white, which has some generalizability issues, but there's some other research coming out that makes it more generalizable. It's 3 weeks apart, and you can see here that it was 95% effective, although they didn't look at asymptomatic carriers, but against symptomatic disease. And there was, a fair amount of injection site, pain, redness, swelling at the injection site that usually goes away in a couple of days, and then fatigue and headache that also was present. These are lower numbers. This is more severe fatigue and headache. And then the interesting thing is there's been a lot, Israel has done a sort of exclusive deal with Pfizer, and they've now vaccinated 44% of their population has received at least one vaccine already. So you can see here that what they have found and what they've been putting out is even after one vaccine, you can see here the effects. So protection from the Pfizer vaccine, and here you have 1 million people that are being studied. Okay, so they looked at almost 600,000 people that were vaccinated, and they found a control match for equal number of folks. And then what they found here is the first row says, okay, they got one dose, and what did things look like 14 to 20 days after that first dose? And you can see here that you had a protection of 46% of a documented infection, 57% of the protection becoming symptomatic, 74% reduction or protection in being hospitalized, and so on and so forth. 62% of severe illness and 72% protection from dying, just from the first dose alone. Then they repeated that study, looking at it 7 days after, at least 7 days after the second dose, and you can see there really high numbers, right? So you get severe illness and 92% protection. They didn't provide any death data on that, and I think it's because it's ongoing. I was a little confused by that when I read the paper. If you're interested, it's a New England Journal of Medicine paper. It came out February, early February. So pretty exciting, big numbers. We're talking about 1 million people being studied here. And so what about Moderna? So Moderna, there were about originally 33,000 folks studied. Sorry about the commas and the spaces there. All adults over 18 years of age. The dosing was 4 weeks apart. Again, roughly the same, 47% women, 25% were over 65, greater than 1/3 were from communities of color. A big proportion were at high risk related to their occupation, with 1/4 of them being healthcare workers. And they found 11 cases that happened in the vaccine group, and 185 cases amongst those that didn't get the vaccine. And you see here severe disease. There was 1 case that was found later in retrospect. First it was 0, but then they found there was 1 case of severe disease in the vaccine group and 30 in the placebo. So they also looked at, which is interesting, some early data looking at just before the second dose, how effective was it? They swabbed them just before the second dose, nasal swab. And amongst those being swabbed just before the second dose, they found 39 in the placebo group that were carrying the virus, against 15 in the vaccine group. So that's a 62% reduction in the likelihood of carrying vaccine in you once you've had the first dose of vaccine. And then they sort of looked at all infections, so symptomatic over time, up until that point in time, not just at the time of swabbing. And they found an 80% reduction. So 80% reduction in being infected, symptomatic or by PCR, is huge, just after that first dose. A lot of local reactions, again, that arm swelling and sort of stiffness. I had the Moderna vaccine. I can tell you my arm was, definitely a bit sore. It wasn't horrible, but it was definitely sore and painful and warm. And you can see for systemic effects after the second dose, 79% experience some sort of effects. In the placebo group, 36% of the people had some systemic effects. So it always makes it's sort of interesting. You get an injection and how much our own mind can create body phenomena. You got 36% of people having body phenomena here, and systemic, not just local, but systemic reaction. So they're receiving like the saline push. There's nothing in it but salt water basically, and yet 36% are experiencing headaches and body aches and fevers and whatever else they're saying that they're experiencing. On average, it was 2 to 3 days, and it was more common in those under 65 years of age than over 65 years of age. And the reasons for that is our immune response is less robust as we get older. And so as you get older, you have a less robust response. These systemic reactions are our immune system itself, our cytokines and different parts of our immune system that are creating this immune response. So we build up our immune system to then fight the virus. And in that process of building that up, we get this response. It's not from the actual vaccine itself, it's our response to it. So if you look here, sort of a summary page that you could see here after the injection site adverse events after the first dose versus the second dose, you can see more folks in the placebo arm, actually almost double, had something after the second dose, which is sort of interesting. But you've got roughly 80% of folks of getting the vaccine had some sort of response. The next graphical display there below is days since randomization and cumulative incidence. So that's what's the number of people getting sick with COVID. And you can see the purple line being the placebo versus very, very few cases amongst those that got the vaccine. And the numbers are down here. So 2 doses of this Moderna vaccine were safe, provide 94% efficacy in adults. So I think it's a better way to display the systemic reaction. So I thought I'd this is from their paper that they published, and I thought I'd put it here for you to see. because when they quote only, you know, 2% grade 3 reactions, where grade 3 are quite serious reactions. But you can see here that most people had some sort of response. That's what the right, if you look here under any adverse event, and you look at the right two columns, those are the folks that got the vaccine. On the left two columns are those that had just placebo. So you can see the gray is grade 1, blue is grade 2, this is a severity scale, and red is grade 3 for any adverse event. So, you know, 80% after dose 2. Pain was, you can see right there, the large predominant factor. If you go down the second row here, you can see here, some people had chills, you know, roughly 40% had some sort of a chills, some sort of a arthralgia, some sort of a joint ache sensation, roughly, you know, a third. Body aches of some sort, roughly half. Fatigue, roughly a half. Headache, roughly half. And so this is sort of the local, sorry, the top one is local. So that's pain at the local site, redness, swelling at the local site. And the B down here is more systemic. My experience was I didn't have an actual fever, but I felt warm. I did have this mild headache. I had significant fatigue, significant body aches. All my joints felt like they were sort of filled with fluid. And I woke up the second night, like pretty soaked. And then the third day, it was as if nothing happened. So let's talk about the Johnson & Johnson vaccine. This one was recently approved under EUA. It's one dose. They just need to refrigerate it. It was studied across the globe in 3 different main, you know, continents, if you will. So the US, Central South America, South Africa, which was fortuitous for us given the South African variant. So we can see how this vaccine performed under those circumstances. And then you can see the demographics of white, Latinx, African-American, Native American, and Asian. And what you see here is outcomes after 14 to 28 days after the dose was given. So they had 468 cases of symptomatic COVID. They had 0 hospitalizations or deaths amongst those that got the vaccine. For those that had severe disease, it was 85% effective. And you can see here it's 89% effective against severe disease in South Africa. And the predominant strain in South Africa is this concerning strain that's thought to be more mutated than the other strains out there in the world. And there's more concern about how our vaccines will respond to that strain because it's more different than the original strain and the other mutated strains, the UK strain, the Brazilian strain. This performed quite well, 89% effective against severe disease. Against moderate disease, you can see across the globe, it sort of behaved differently in different locations. This still did fairly well. There's no full paper that I could find that's published yet, really a press release and some other related stuff. So there was no mention of injection site reactions. They say 9% had fever. I don't know, it was at a grade 3 fever or grade 1 fever, I'm not really sure. And overall, the severe adverse events, SAE means severe adverse events, were actually higher in the placebo group. No one had anaphylaxis, and there are some very rare cases of anaphylaxis in the mRNA vaccine. There was a new paper that came out that showed, looking at rising, that's supposed to say rising neutralizing antibody, that was all the way out to 59 days. So there's an increase in one's neutralizing antibody, which is one of the different immune responses that we have, the categories of immune response. And it kept increasing. So the paper itself, the trial itself originally was just done looking at outcomes from day 14 from the original or an only dose of vaccine to 28 days out. But then a subsequent paper has been tracking people over 59 days in a subgroup, and they found increasing immunogenicity, even more and more robust immune response as time went on, which is great to hear. I'm looking forward to actually seeing the paper so we can really dig into it. JAMA put out some nice material, and I thought I would just put it here for us to review. You know, what is the Johnson & Johnson vaccine? And this is a technology that doesn't use the mRNA technology, which is new. This uses technology that's old, we've used before. And they take an adenovirus, which is a common type of a respiratory infection. and they use a type of adenovirus that most of us haven't been exposed to yet is the goal. And then the DNA in the adenovirus is modified so that it produces a key part of the SARS-CoV-2 particle, which is this S spike, to which the body then develops this immune response. And the adenovirus delivers the SARS-CoV DNA particle in a way so it can't multiply, so it doesn't actually cause infection. The adenovirus can't start multiplying in our cells and create infection. And so, these DNA molecules are quite stable, so that's why it can just be refrigerated. It doesn't have to be in a deep freeze. And how do these differ from the other ones? As I mentioned, mRNA versus the DNA adenovirus. The mRNA is protected by this lipid nanoparticle membrane, if you will. And so it's highly unstable. That's why it has to be so much in a deep freeze. And that if that genetic material is broken down, then it's no longer stable, right? So for this, that's why those have to be kept so cold, and this one doesn't have to be kept so cold. And here's sort of a graphical display of that conversation, which is that the surface of the SARS-CoV-2, right? That's what we're sort of looking at here. It has this S spike, this unique sort of characteristic, and that's what the surface is sort of covered with. So, and that helps the virus enter human cells. So. The spike protein itself is the target for the vaccines. So to create a viral vector vaccine, the gene for the SARS-CoV spike protein is added to the DNA of a different type of respiratory virus, this one called adenovirus 26. So that adenovirus is modified so it doesn't cause illness. And you can see the spike protein DNA is inserted in the adenovirus. And then that's then injected into our body. So unlike the mRNA, which actually only stays in the cytoplasm of the cell, this vaccine actually enters into the nucleus of our cells. And then this spike protein then goes into the nucleus, and then that cell then will create spike proteins on the surface of our own cell and then create an antibody response when it does that. So the cell uses the viral DNA to produce spike proteins. This activates the body's immune system to produce antibodies and immune cells that recognize the spike protein. So, and then so hopefully that's helpful. It shows you the differences between the two. This data is a little different. So this has shown that, to produce antibodies against SARS in 90% of people who receive the first dose. So it's approximately true. The amount of antibodies was greater for those who received 2 doses. Actually, there's some studies now, right, looking at 2-dose regimen versus the 1-dose regimen, and no one developed severe reactions. So that's sort of the tour of the 3 different vaccines. And just to pause for a moment, and if anyone has any questions, one of the main big questions people ask is, can I which of these 3 should I do? I don't have a clear answer to that. As more data comes out, we'll know. My immediate response is whichever one you can get your hands on first is the one you should do. These are all, as I said, showed you in that initial graph or table, really effective. I think there was the reactions a lot of people are afraid of, and they heard the Moderna vaccine, you have a greater reaction than the Pfizer vaccine, and that the Johnson & Johnson one's even lesser reaction. It's only 1 vaccine. In my view, it's super transient. It's not that bad for most people. And amongst those where it has been difficult, it's like having a short-lived flu that lasts, a day or 2, not, typical 5-day flu. So that's my immediate response, is to do whichever one you can get access to. Any other questions that come up? There's one question here, thinking down the road, given that the slight differences, would it make sense to get another version of the vaccine in another year? For example, the Pfizer this year and the Johnson & Johnson next year. So I speak to some of what you're saying later in the talk, but let me talk about it now. Well, first, they are starting to do studies where they will mix and match, because vaccine accessibility is complicated, logistics are complicated. So they are starting to do studies where they'll give one Moderna and the second one's Pfizer, or one Johnson & Johnson, the second one is Moderna. And that's sort of mixing and matching, and to study that. Some of my patients that I know that are overseas have had that conversation. You know, should I have access to one vaccine here in my country where I'm living, and I'll just get a second vaccine being a different type of vaccine in the United States. It hasn't been studied, and it's mixed. Talking to different vaccinologists and infectious disease people that I've spoken with, I've mixed responses. I've heard, yeah, that's probably going to be just fine. And I've also heard we don't really fully understand how our immune system primes itself, and it could actually go negatively. And you could prime yourself so that the second vaccine actually gives you less effectiveness than having done the same type of technology both times. So there's clinical trials happening, and I think that'll be helpful to look at that mix and match clinical trial. Then the question being boosters. So the nice thing about the mRNA technology is it's very manipulatable. So they can quickly create a variant or a booster vaccine that handles variants and mutated vaccines. And they're already doing that right now. So I can easily see by the fall a booster vaccine that then handles the new variants that we have found that the current vaccine isn't covering. And hopefully the mix and match studies will help us figure out the question of, well, this year I'll get Pfizer, next year I'll do the Johnson & Johnson, which is an adenovirus. And so it'll help us look at, actually that does give you a more robust immune response. And right now we don't really know. All right, if there aren't any more questions, I'll keep moving through. So let me just, so let's talk a little bit about vaccines and do they reduce transmission. I was going for a hike with someone yesterday, and they're wondering, like, how should we be wearing masks together when we're outside? Like, can you still give me the virus since you're a doctor and you're putting your hands and swabbing people and helping with vaccines and administer vaccines and through the Veterans Hospital and all the stuff you're doing, you know, could you be carrying virus and giving it to me? So the take-home message is we really think that's highly unusual, and for a couple different reasons. So number one, biological plausibility. So we know that IgG antibodies measured in trials are really high in the nasal mucosa. So, and when there's high IgG antibodies, we know that really knocks down the virus. We also know that there's systemic vaccines induce an IgA response, and there's the predominant response that we have around our mucosa is the IgA, which is like, for example, allergies are a big problem related to IgA as well. So when you have a sort of a negative response to things that are allergens. So we know that inducing an IgA response, it wasn't measured in these vaccine studies, but we know in other studies that happens. So again, we have IgA, we have IgG. We also know that looking at monoclonal antibodies that we've given to people, that it hastens viral clearance from the airways. That's been studied. So we can presume that the vaccine antibody response, which is not monoclonal, it's really polyclonal, would do the same. And also there's some challenge experiments that have been done in primates showing that viral replication can be blocked in the bronchial alveolar lavages, so in the respiratory airways, and in nasal swabs. So we know that viral replication can be blocked in the setting of being vaccinated. So again, a whole bunch of biological reasons why we think it's very unlikely. Some real world data, we know that looking at those that are actually greater than, those that are older than 60, sorry, this says less than 60, but amongst those that are older than 60, 90% of them have been vaccinated in Israel. And we've seen a dramatic reduction in the number of cases and hospitalizations amongst that group. So thinking about a cohort effect, we've seen a reduction there. We also know there's some papers out looking at the viral load. And so we, number one, know that transmission of COVID is highly correlated with the amount of virus you're carrying in your nasal passages. And the second study that's part of the Pfizer's has this in Israel, have this collaboration where they're pumping out a whole bunch of data. this collaboration that's currently published in the medRxiv. So it's not a peer-reviewed journal. This is like you write a paper and you try and get it out so the public can review it and other scientists can review it and then add on to the science they're doing. It's called medRxiv. Hasn't been peer-reviewed yet, but they've shown a fourfold reduction in the viral load after vaccination. So amongst Israelis that have been vaccinated, they see a fourfold reduction in viral load. Again, dramatically reducing the likelihood that you'd be able to transmit it to someone else based on those papers. So that's all great news, and should make us all feel a lot more comfortable. And so what does that mean, practically speaking, and I'll get there in a sec. So another question that came up, are they studying any long-term possible consequences of the new kinds of vaccines? Yeah, so they are, of course, and they can't do it in humans long-term until time goes on. What we do know, again, this is why I brought it up earlier, and there's a lot of manipulated information out there from people that either don't understand the science or just anti-establishment, understand the science but are just against the establishment and want to push against it. It's a little unclear why people are promoting this, but what's being promoted is that these mRNA viruses can change your own DNA. And there's zero truth to that. So if you understand the science, you would know that's not possible. So these mRNA vaccines don't even go into the nucleus of our cell. So that makes it, far more complicated than number one. Number two, they don't last very long at all. They immediately, die off. So it goes into our cytoplasm, and then we then generate what's needed of our own body to then go into the nucleus of our cell to then create the process that happens. The DNA, the adenoviruses, for example, the Johnson & Johnson virus does go into the nucleus of the cell. Those, and if there's a theoretical possibility that would mutate our own DNA, then we would have seen that in other vaccines. I've heard some actually medical doctors saying that it's going to make us aliens. It's just complete ludicrous conversation. So with that said, are there some unforeseen consequences of the vaccine? It's possible, and so it definitely will be studied. But no one that I've spoken to foresees it to be a problem. And they can't understand how biologically it would be a problem. All right, so moving on, let's talk about the variants. And should we be concerned? What we do know is that the vaccines have been shown to modulate the severity of illness, which is great news. So regardless, even if something was highly mutated, we know you would have a less severe experience of that infection, even if there was a very extreme variant. The second is we do know that it does mutate, but because RNA viruses do mutate. But interestingly, it hasn't mutated as fast as, for example, influenza has and does. We do know that the neutralizing antibody titers are really going up and progressively so, and that's quite reassuring. We also know there's a broad repertoire of our immune response. We have T cell responses, we have B cell responses, and antibodies that are all listed from the vaccine. So again, that broad repertoire really makes it more difficult for these variants to escape the immune response. And then we've seen some reassuring data from the J&J studies that I just showed you out of South Africa, showing that the 89% effectiveness, and AstraZeneca trials as well, and with those variants. So far things look good. The other part that's nice is certain vaccines, particularly the mRNA vaccines, for example, can be readily tweaked, and that will allow us to create boosters for the future. So, and that's currently happening as well. So I'm feeling pretty confident about how quickly the science is moving, and B, how fortunate we are that the mutations that have happened so far are ones that I believe our vaccines are pretty well capable of handling. But we'll see as time goes on if we're proven wrong. But most of the scientists I speak to are pretty optimistic. So let's just talk about, some of these, the variants are more infectious, right? It's easier to get, the R naught is higher than we previously known to have for the original variants. And those then become the predominant strain over time, but they're more infectious. So what to do about that? There's a lot of conversation about double masking. What does that mean? So President Biden, you see, is wearing an N95 mask and then a surgical mask over that. That's probably the highest protection you could possibly get. The N95 mask being the highest and most highly filtered mask, and then the surgical mask being next up. The advantage to that is just what I said. The disadvantage is comfort and likelihood of people to be wearing it correctly, because as you can see here, the N95 mask, if anyone's worn one, they're quite uncomfortable to wear. You can wear them for a day, or I'm sorry, for an hour. You can wear them if you had to for a couple hours, but they're really tiring to wear, and you can ask healthcare workers about this. And the fit, when done properly, is really quite tight, so that no air escapes at all. So from around the seal, and then you're filtering through this N95 mask only. When you're wearing the surgical mask, it's a little bit more comfortable, and obviously the cloth mask more comfortable. So what are the options? Practically speaking, many people are doing what you see on the right, which is a surgical mask, and then the cloth mask over that. What the cloth mask does in that scenario is it actually provides a better fit of the surgical mask, because it sort of pushes it down and helps give you a better fit and a better seal of that surgical mask, which is good. And then it provides 2 layers of protection. A third option, which many people are doing, which really has been double masking all along, is they wear a cloth mask that has inserts, and you can put N95 level filtration inserts into that cloth mask. And so in essence, you have one strap going around your head with this cloth mask, and inside of it is yet another filtering system. And that's really a nice way to do it. So I'm in favor of sort of what you're seeing here on the right with this woman wearing, or a cloth mask that has good fit to it. You would like a cloth mask that has good fit, meaning that it has a metal piece, some sort of metal over the top of the nose, so you can actually sculpt it to your particular face, cheekbones and nasal bridge, because you can have all this filtering system going on, but if you're breathing through the sides of the mask, coming in and out, then it defeats the purpose, obviously. But most people don't think much about that. So Monica Gandhi and a few others here have come up with this concept, which is pretty common sense, but worth speaking into more, which is we have this sort of, fortunately, a range of different levers that we can push and pull to create safety. One is thinking about distancing, the others were thinking about masking, and the third is thinking about ventilation when we're thinking about our exposure risk. And so if you're outdoors, how much masking do you need to do, and how much distancing, right? So if there's great ventilation, then you can modulate your masking and distancing accordingly. And if there's poor ventilation, which I've seen in a lot of outdoor eating environments, actually, where you'll see like there's an outdoor situation where, and I should put up a picture of this. I took a picture, it was in the marina on, I forget which street it was on now, but you could see like a 20 foot high buildings, a narrow sidewalk that maybe was 6 or 8 feet. And then they put the outdoor seating areas right on the edge of the sidewalk that has plastic roof, plastic wall here, and a wall on each side. So basically what you have is a wall here, a ceiling, a wall on this end, and a cap on this end. And then you have you'd think would be good ventilation because this is all open, but then you have a 20 foot high building sitting 6 feet over. So and then it's packed. So, and you have people coming back and forth. So that is not good ventilation. You know, if there's a lot of wind or they have fans in place or they have filter systems in place, that's one thing. But as you probably have seen in the marina, that's not happening. So I would not consider that a safe space. And the sad part about that is people are eating, so they have their mask off. And the physical distancing is actually quite condensed because people are sitting across from one another at tables. And then there's tables stacked right behind them and next to them. So that is not a good environment. And I don't recommend people spend time there. Whereas you go to other environments that, you know, you can see, for example, in Mill Valley, downtown Mill Valley, they had outdoor seating. Or you can see actually up on the Fillmore, along Fillmore and along Post, there's actually outdoor seating where it's in the city, where it's in San Francisco, where it's actually quite spacious. There's good ventilation. People are 6, 8, 10 feet apart from each other at the different tables, different scenario. So it's a big concern for me around eating because everyone has their masks off and distancing is compromised. So you really want to emphasize ventilation. And then flip side, if you're going to someone's home, poor ventilation typically, unless someone's, you know, has a HEPA filter running and doors open and windows that are across from one another. So how do you improve ventilation? We've talked about before, but I'll just reiterate because a lot of us forget, is you want opposing walls ventilated. So you want a door open here and a window open here on opposing walls so that you get cross breeze. And you can have fans running in the house, manual large fans. You can also have a HEPA filter system in your home to actually filter out virus and other particulate matter. And that way it will allow for a lot more comfortable experience. Okay, so the other conversation I feel like it's worth having is to think about this more tiered approach. So how can people hang out together? And I think Fauci actually was bringing this up. And so Monica Gandhi, I think she's the one that may have created this slide. It's a nice way to think things through. So if I'm with someone who's vaccinated and I'm vaccinated, we should be able to feel free to mingle without restrictions because the risk is so low. It's a 5% chance of me getting infected and then a 5% chance of someone else getting infected. So if you do the math on that, then you have 5% of 5%. And as there's actually an example of one of the leaders in Europe saying, I want to get my vaccine so I can go hang out with my friends that are all vaccinated and hug and hang out and, be affectionate again like I used to be. Then you have the vaccinated around unvaccinated and in public, keeping masks, distancing, given very small, unlikely chances of asymptomatic infection until there's more data. So that would be, in other words, saying it's sort of a modulated approach that you should keep your mask on, you should be distancing, you should think about ventilation because there is a small risk. Realizing the risk is quite low, but we do need data, but I just showed you that we think the chances of me giving SARS-CoV-2 to someone is really quite low. But nonetheless, given their current political environment and sort of social norms, I'm fully wearing masks all the time and keeping distance because the last thing we need is people claiming that they're vaccinated when they're really not. And then you have the unvaccinated with unvaccinated, which is the vast majority of the population in the United States, and keeping all restrictions as we're currently doing. So that's really most of the material I wanted to cover today. And let me see if there's any more questions. Feel free to please bring up questions, topics that I didn't cover at all, or other related questions you have. So here's another question: is there more evidence on COVID being on surfaces? People don't seem to be as concerned about that. Yeah, so the concept about fomites and whether or not we can actually get COVID from touching surfaces and packages, it's really thought to not be a primary mode of transmission at all. It's theoretically possible. Someone sneezes on a counter and then you go by quick, within a reasonable short time frame and touch that surface, and then touch yourself, that you could get infected. Similarly with a common cold, right? So, but as a primary mode of infection, no. So should people be wiping down their boxes when they get shipments in their mail? No, I don't think people should be doing that. That's not necessary. That's overkill. So, and similarly, do I think it's wise that we're sort of wiping down the grocery carts when you go in the grocery store? Yeah, because people have their hands there, they rub their eyes and nose, possibly, or sneeze, and then you're putting your hand there immediately right after, potentially. Cart goes in, you walk by, you didn't know, just went in there and you grab it. So I think wiping that down makes sense. But as a primary mode of transmission, it's no longer considered that. Yeah, so let's talk a little bit about, thank you for that question about vaccine ramp up and timing. There's clearly increased ramp up with Pfizer and Moderna in the United States, and thankfully improving logistics from the government, from the federal level into the states happening. Also, Johnson & Johnson is ramping up their manufacturing too. So I anticipate, as many of you know, come March 15th, those with a significant comorbidity that dramatically increases their risk. If you're an adult, you are now eligible to get the vaccine. So it's 65 and older up until now. They're doing sort of certain subsegments of essential healthcare workers that are at risk for exposure, effective March 1st. And now starting March 15th will be a large sector of our population, actually, which are folks that are at very high risk. So those for end stage kidney function, for example, those who've had heart attacks before. Those are on immunosuppressant drugs so that they're immunocompromised. Those that are organ transplants that are on, for example. So that category of individual will get access March 15th. I anticipate that by end of March, by April, we'll really have a significant supply. And I think that it'll be actually quite easy for people to get vaccinated come April into May. That's my understanding of sort of how the ramp up is going to go. And so I feel thankfully good about that. It feels frustrating for many of us to think about it because, you look at Israel, for example, and they've done an amazing job vaccinating their population. The United States is obviously much larger, much more diverse, and we obviously had an administration that wasn't focused on a federal approach, national approach, which is what is needed in order to have an effective vaccination campaign. So we're a bit behind the 8 ball, but we're rapidly, within 4 months, if you think about it, December, January, February, March, by April, month 5, I think we can feel more confident that the supply is really going to dramatically increase. I will also say, there are people that I hear about that get lucky and get vaccinated. Usually, they bring a 75-year-old to get vaccinated, and they towards the end of the day, and they happen to have an extra vaccine that they're able to get because they can't reach anyone else on the wait list. But it's pretty rare. It's definitely a rare event. I've been poking around trying to get a sense for that, and it's definitely a rare event. Although, it's an online conversation that's happening. All right, well, thanks for everyone's attention. If there's no more questions, then we'll bring it to a close. For those that are in the practice, we'll be having another conversation next week. I hope you can join that, more about what's going on within our medical practice and specifically, and some more updates there. And we'll do this on a monthly basis as well. So thanks for your time and your questions. They always help me stay on my toes and help me learn too. All right, take good care. Bye.